Dear colleagues, I'm going to present the preliminary results of this study, which was approved by the local ethics committee. As it was recommended by the scientific committee, and before I present our study, I state that I am aware of and have disclosed any potential conflicts of interest or support that might cause a bias in my presentation. It investigated the null hypothesis that venous thromboembolism in patients undergoing elective total hip or total knee replacement was not different when either intermittent pneumatic compression or low molecular weight heparin were prescribed. A written informed consent was obtained from all the patients before randomization. Patients undergoing elective primary unilateral hip or knee replacement at hospital were considered for enrollment in this study. Consenting subjects were randomly assigned into two groups. Group 1, where intermittent pneumatic compression was used, and Group 2, where enoxaparin was prescribed. In Group 1, IPC with calf garment commenced on operative day with IPC applied to the non-operated side during surgery and to both legs post-operatively until fully ambulant. In Group 2, enoxaparin 40 mg was injected 1 day preoperatively and after that daily from the first post-operative day until hospital discharge. No compression stockings were used. Exclusion criteria included a history of venous thromboembolism, long-term anticoagulation treatment with vitamin K antagonists or low molecular weight heparin, pre-existing cardiac or cerebrovascular disease necessitating a continuous treatment with clopidogrel, an inherited or acquired hypercoagulable state. Patients treated with aspirin were enrolled. Aspirin was not stopped during the whole study, except in some cases on the anesthetist's request. All eligible patients underwent duplex ultrasonography of the venous system in both legs and thighs on preoperative day to exclude any venous thrombosis. A posterior approach was used to replace the hips with cementless components. The knees were anteriorly approached under a pneumatic tourniquet. The components were cemented and the tourniquet was deflated after the wound dressing was closed. General or spinal anesthesia were nearly always combined with local-regional anesthesia by infiltration of the lumbar plexus or femoral and sciatic nerves. Analgesics and anti-inflammatory drugs were given for control of postoperative pain. In some patients, anesthetic agents were injected in catheters located along the lumbar plexus or the femoral nerve during the 2 first postoperative days. All began mobilization exercises under the supervision of a physiotherapist within 24 hours after surgery. Immediate full weight bearing was allowed, and walking rehabilitation was started as early as possible, generally at postoperative day 2 or 3. Here are the data of the first 101 patients who could be followed for at least 1 year after surgery. 55 patients were in Group 1, intermittent pneumatic compression, and 46 in Group 2 who received enoxaparin. There was no difference of sex ratio, patient age, body mass index, ASA score, and anesthesia techniques between the two groups. The primary efficacy outcome was assessed by bilateral ultrasonographic studies of the calf and thigh veins at day 7, 8, or 9 often just before discharge from hospital. Only one distal deep vein thrombosis was detected by ultrasonography during the hospital stay in each group, both in male patients undergoing knee replacement. This DVT remained asymptomatic and no medical anticoagulant therapy was given. The clinical examination was strictly normal 1 year after arthroplasty. No proximal DVT or symptomatic pulmonary embolism occurred during the hospital stay, and no anticoagulant prophylaxis was prescribed after hospital discharge. At the first follow-up visit, occurring between 6 weeks and 3 months after surgery, a foot and leg edema on the operated site was present in 5 patients from group 2. Duplex ultrasonography could not demonstrate any DVT. These patients were 3 women after knee replacement and 2 men, one after hip and the other after a knee replacement. At least 1 year later, no DVT or pulmonary embolism occurred, no bleeding, wound complications or other severe clinical event, except that 1 female patient died at the age of 84, 3 years after hip replacement, due to a septic shock unrelated to the initial surgery. The amount of bleeding was assessed by the measurement of perioperative blood loss, the volume of blood collected in the drains, and the volume of blood transfusions. The hemoglobin level was measured several times postoperatively. The lowest level was subtracted from the preoperative level in each patient to measure more precisely the amount of blood loss. Extended bruises were frequently present. Consequently, blood loss could be underestimated when it was assessed only by the volume collected in the drains. The percentage of hemoglobin decrease was similar in the 2 groups. The volumes of blood loss measured perioperatively and collected in the drains during 48 hours were not different. The number of patients for whom a blood transfusion was judged necessary was not different, and the volumes transfused were similar. But despite the randomization, and because the series is still too small, the knee arthroplasties represented 44% of the surgical procedures in Group 1 and 70% in Group 2. Consequently, we looked for a difference in the bleeding amount between patients with hip or knee replacement. Although blood loss seemed to be greater in TK patients treated with heparin, the percentage of hemoglobin decrease was similar in all the subgroups. There was still a difference between patients of the 2 groups. The ratio of patients previously treated with aspirin was greater in Group 2 than in Group 1. While this treatment was stopped in nearly all the patients in Group 1, it was maintained in half of the patients in Group 2. This difference could explain greater blood loss in Group 2 than in Group 1. The preoperative level of hemoglobin was similar in the 2 groups and decreased by the same amount, 28% of the preoperative level. In Group 2, where 30% of the patients were previously treated with aspirin, we observed that aspirin was maintained in 6 patients who were significantly older than those who previously never took aspirin, and total blood loss, as well as the percentage of hemoglobin decrease, was significantly greater. From this preliminary study, we can conclude that the incidence of venous thromboembolism was rare, whatever the prophylactic measure used. We diagnosed with duplex ultrasonography only 2 asymptomatic distal DVT in 2 male patients undergoing knee replacement. No anticoagulant prophylaxis was used after hospital discharge. no further DVT or pulmonary embolism occurred after at least 1 year follow-up. This VTE incidence of 2% is similar to the VTE incidence reported in coronary arthroplasty patients without chemical thromboprophylaxis. This study doesn't reject the null hypothesis, and thromboprophylaxis with IPC alone is as effective and safe as LMAWH injections for patients undergoing a primary total hip or knee replacement. At present, we cannot demonstrate any difference of blood loss, blood transfusions judged necessary, or wound complications between the two groups. Nevertheless, when a previous treatment with aspirin is maintained, the total blood loss is probably greater. For these cases, we could prefer thromboprophylaxis with IPC rather than with LMWH. But this study has to be extended to 200 subjects for valid statistical analysis to be conducted, and a larger study might give different conclusions. I thank you for your attention. My co-moderator,